We'll get to know.
This meeting is being recorded.
Forward to meeting for the very first. There are those we look up to, those who taught us everything, those we share our lives with, and those we look forward to meeting for the very first time. Though we all belong to a generation, not everyone has a chance to help create a new one. No more than one generation ago, the world of fertility care changed forever. With Louise, we saw what was possible with IVF. And today, she and millions of women, babies, and families have become generational symbols of courage, knowledge, progress, and change. But as the need for fertility care continues to change, there are challenges we must overcome. As global demographics are changing, fertility rates are under pressure. As technology is advancing faster than ever, clinics and patients still need the tools, time, and training to turn data into informed decisions. And the limited access to quality fertility treatment is a global reproductive issue that needs to change. At Cooper Surgical, we are proud to offer leading IVF and genetic testing solutions to clinics around the world. We believe in pushing the boundaries of what is possible, that together we can change the standards of fertility care to increase the time for patient support and consistently optimize outcomes, change the journey in fertility care to reach a higher level of insight, efficiency, and trust, change the access to fertility care, break down the barriers standing in the way of parenthood. That's how, together with her, him, her, they, them, we can make the change every generation deserves, a chance to bring new generations to life. Cooper Surgical, changing fertility care for generations to come.
So good evening, everyone. So we have participants, almost 32 attendees are joining. So we are live. Good evening, everyone. We welcome you all for today's exciting webinar on Let's Learn Semen Analysis. This is the first webinar of the educational series direct from Andrology Lab, which has been started by IHERA, the International Human Embryology Research Academy. And we at Cooper Surgical are truly honored to be the knowledge partner for this series. So without any further ado, I would like to start the evening and would like to start introducing the coordinators for the event. We start with Dr. Nidhi Singh. She's a consultant and clinical embryologist. She's worked at Vardhaman Mahavir Medical College and Safdarjung Hospital, along with Center of IVF and Human Reproduction at Sir Gangaram Hospital, and IVF and Reproductive Biology Center at MAMC and LNJP Hospital, New Delhi. Welcome, Dr. Nidhi.
Good evening.
The next coordinator for the evening is Ms. Yoshita Tanwar. She's a senior embryologist and laboratory in charge with 8 years of experience in the field of embryology at New Life India Fertility Clinic. She's certified in advanced skill set embryology training conducted by Merck. She's also an ASRM certified clinical embryologist, member of ACE India and ASRM. She's also a team member at IHERA. Welcome, Dr. Ms. Yoshita. And the third coordinator for the evening is Sharma. He's a chief embryologist and lab manager at IKDRC, Department of Reproductive Medicine at Gujarat. She's
ASRM certified.
She is an ASRM certified embryologist and has certified from ASRM in fertility preservation for reproductive health. She's also done training on embryo and blastocyst biopsy from UCL. She's done her embryology certification course from Indian Fertility Society and has experience of 7 years in the field of ART. She has more than 13 research papers internationally as presenting author. She is a PhD scholar and postgraduate in molecular biology and biochemistry. And she is, of course, the team member of IHERA and also along with prestigious national and international societies such as ASRM, ESHRE, ACE, and IHERA. So we welcome all three of you to coordinate the event tonight. So the stage is up to you. Please carry on.
Yeah, good evening to all. I'm Dr. Nidhi Singh, and let's learn about semen analysis. So beginning with this, I would like to welcome our founder of IHERA, Dr. Peter Kasser. He's a lab director of Southern Fertility and IVF Center and the president of ACE India. He is the member of Virtual Education Committee and SSR from 2001 to 2022. And he's a faculty fellowship in ART, Amity University, Noida. He's a visiting faculty and MSc ART, Mysore University. He has 8 chapters contributed in textbook and published multiple papers in national and international journals. And his areas of interest is in vivo fertilization to blastocyst formation and innovation in embryo culture system. Good evening, sir. We welcome you all. Next is Dr. Sanjay Shukla, sir. He is the co-founder, lab director at Baheti Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. He has done PhD in life sciences, worked on early diagnosis of typhoid fever. He is working in this field of human reproduction since 1998. He has a fellowship in 2006 in biology of reproduction from Centro de Estudio, Argentina. He's a vice president of ACE India. He's chairman, academic wing, ACE India. He's the editor and newsletter of Academic of Clinical Embryology, ACE India. Welcome, sir. And third, the co-founder is Dr. Charudha Joshi. He's MSc PhD ART from Belgium. He has done his post-graduation in life sciences in 1993, special training in ICSI and IVF and sperm from Belgium, and embryo freezing from KK Women's Hospital, Singapore. He has done special training in laser-assisted hatching from Belgium in 2006, in PGD from Germany in 2008, and has done doctorate in life sciences in 2018. Sir is the executive committee member of MPSR chapter and MPIFS chapter. Sir was the vice president of ACE Academy, the past president of ACE Academy 2014 and 2016, and is the medical director of Genes India ART Bank. Welcome to you all, sir. I would request Dr. Peter Kasser to please say a few words. Sir.
Thank you, Nidhi. Thank you so much. Actually, first of all, I want to congratulate all of you, both 3 coordinators, Dr. Nidhi, Yoshita, and Dr. Nancy. They have done a wonderful job, and I have seen that all the presentation they share with me for semen analysis, and I hope everybody will enjoy and learn so many things today. And semen analysis, we all think it is a very simple thing. It is we can do in a minutes, but it is not like that. And somehow in IVF lab, most of the people think semen analysis has no role left now, because we put 1 drop and decide on that drop. We have to go for IVF and ICSI. So we have expert Dr. Jayalakshmi Shetty. She will tell you what is the importance of that. So with that, I hand over to coordinators, and maybe Dr. Charudha Joshi want to say something before starting.
Yeah, good evening, everyone. Yes, this is indeed a very good startup brought by IHERA. And I also feel the same thing, that the semen analysis is now a very neglected part in infertility practice, and everyone just make a drop and see, and then we decide DNA fragmentation, high, low, it doesn't matter, simply do ICSI and all. So I hope today's our initiative will throw some light on semen analysis, and people will able to understand. I know Jayalakshmi from a long time. Hello, good evening, Jayalakshmi. So she's done a lot of work in this semen analysis. So let's hear from the experts. All the best. Over to you, Nidhi.
So, I'm audible. Yeah. Good evening. I welcome Dr. Jayalakshmi Shetty. She's consultant embryologist, Andro Healthcare, Bangalore. She has done BSc in biotechnology from Bangalore University and diploma in genetic engineering from Jain College, Bangalore, 1999. She has done MSc biotechnology from Kuala Lumpur University, 2012. Has been an embryologist in Guneshila IVF Center from last 9 years. She's a senior embryologist at Morpheus Life Sciences for last 4 years. Senior embryologist at Manipal Fertility, Bangalore from 2013 to 2020. And currently, ma'am is consultant embryologist at Andro Healthcare, Bangalore. Has more than 20 years of experience and is, just a minute. I'm so sorry.
It's okay, no problem.
My screen has totally gone blank, ma'am.
No problem. No problem. No problem.
Again, I'm so sorry. And ma'am she's an expert in this field, and we say that making the base is the most important part of any foundation. So let's start our journey today, and welcome you, ma'am.
Thank you so much.
Ma'am, you can share your screen.
Yeah, sure. Is it visible?
Yes, ma'am.
Yes,
It is
ma'am.
visible.
Yeah.
Yes, ma'am.
Good evening, everyone. I'm Jayalakshmi. Just now, Dr. Ved and Charu sir told that is semen analysis losing its importance in our ART techniques. So I would like to throw what is important in semen analysis, and do we think that it is losing its importance? So let's start with why semen analysis is important. The semen analysis is important to assess the male reproductive function and genital tract patency to enable appropriate treatment for the male subfertility. It is for the treatment response for the male subfertility. That means the treatment is given and how a subfertile male is responding to the treatment can be analyzed by the semen analysis. The analysis is important to identify fertility potential and choice of suitable treatment for an infertile couple, and it is also to measure the efficacy of male contraception or the vasectomy, just to see the sperm production. Male infertility is often due to the insufficient sperm production, abnormal sperm morphology, impaired sperm motility, or combination of all these. All these can be faithfully identified by the semen analysis. Infertility in male is assessed by taking the detailed medical history, sexual history, and a complete physical examination and semen analysis. So semen analysis is definitely important part of this whole workup. The male factor significantly contributes 30% of the infertility cases, and in some cases it is a half contributing factor. Semen analysis is never prognostic of fertility as it is the fertility potential of the couple that defines them as fertile or subfertile. So what is semen analysis? The introduction of in vitro fertilization has certainly revolutionized the possibility of infertile couples to have children. However, the knowledge surrounding male factor for infertility has not been developed to the same extent as the practical experience of searching and finding sperm to produce a viable transferable embryo to the uterus. This means that we are only trying to find a viable sperm, put it in the egg, and then see whether we can get the embryo and can transfer back to the uterus. So we are not actually analyzing the sperm or the contributing factor. We are just trying to make the embryo which can be transferable. Now the main interest, which is limited to established pregnancies, is now shifted to the focus on understanding the causes so that the male infertility can be treated very well. The semen analysis is a lab test that examines the sample for semen under microscope. It evaluates things such as sperm count, motility, morphology, and agglutination, also vitality. The routine semen analysis is a measurement of sperm production, maturation, and ejaculatory process. So definitely, the semen analysis is important diagnostic tool. We have two evaluation when we do semen analysis. One is the macroscopic evaluation. It comprises a number of important observations that may not be quantified. It may not be possible to access its exact numerical value and thereby controlled by the traditional quantitative methods, but these are definitely of great clinical importance. Microscopic evaluation comprises the evaluation of factors which can be calculated and reported. And these values hold great clinical importance in terms of treatment offered to males of fertility. Now, what do we have in macroscopic evaluation? The semen sample is tested for volume, evaluated for volume, pH, appearance, viscosity, liquefaction, and odor. The volume measures the quantity of the man's ejaculate in milliliters. So we calculate the volume in ml. The WHO standard is 1.4 ml is the lower limit. Anything lower than this volume can indicate a partial or complete blockage or dysfunction of the seminal vesicles of the prostate. The pH level should be between 7.2 and 7.8. Sorry. Anything which is less than this is acidic, and the higher pH value indicates the alkaline. Any abnormal pH will affect the health of the sperm, the motility, and the can affect the DNA fragmentation. A normal liquefied ejaculate is homogeneous. The appearance is either cream or gray opal set. If the semen sample is less opaque, it might indicate that concentration, the count of the sperm is low. A slightly yellowish appearance can say that the sample is given after long abstinence. The presence of red-brown color indicates the presence of red blood cells in the sample, which is called hyposomia. A clear yellow appearance might indicate that the patient might have jaundice, or he's taking certain supplements in vitamins, or he's under certain drugs. The complete ejaculation liquefaction. The liquefaction time for a sample is between 15 to 30 minutes at room temperature. If this liquefaction time is more than 30 minutes, it should be reported. Coming to the viscosity, the normal liquefied ejaculate falls in the discrete droplets. When you take the sample in the pipette and drop it, it falls as a small drops. If the viscosity is abnormal, the drop will form a thread more than 2 centimeters long. It is not in droplets, it forms a thread-like structure. The odor of the semen sample has also of clinical importance. So coming to the microscopic evaluation, we generally evaluate for the count, which is the sperm concentration, motility, morphology, vitality, agglutination. Again, you will hear about these things in detail in further discussions. I am just going to say the importance. The total number of spermatozoa per ejaculate and the sperm concentration are related to both time to pregnancy, the pregnancy rate, and are the predictor of conception. The lower the sperm concentration, there is always a chance of pregnancy failure. So evaluation of sperm concentration is definitely important. The sperm concentration is calculated by dividing the number of sperm counted in all the squares in a counting chamber with a dilution factor and the number of squares counted. The total sperm number is the product of ejaculate volume and sperm concentration. Sperm concentration per volume and sperm concentration per ml, and it is multiplied by the ejaculated volume will give you the total concentration present in the ejaculate. According to the WHO manual, the lower reference range is 16 million. Any value which is less than this the count which is less than this is called oligozoospermia. The sperm motility is the ability of sperm to move efficiently. This is important in fertility because the sperm has to move through the women's reproductive tract to reach and fertilize the egg in the fallopian tube. The extent of progressive sperm motility is obtained by multiplying the total number of spermatozoa in the ejaculate by the percentage of progressively motile sperms. The evaluation of motility is an integral part of semen analysis. The progressive motility is important in achieving pregnancy either spontaneously or through basic ART procedures like timed intercourse or IUI. The WHO manual says the total motility should be 42% and the progressive motility should be 30%. Anything which is lower than this reference value is called asthenozoospermia. The fifth manual, WHO manual, has categorized this motility into 3 categories earlier, A, B, C. But now the categorization of sperm motility has reverted back to A, B, C, D. The rapid progressive, sorry, there is a mistake, A, B, C, D, it has to be. Rapid progressive, where the spermatozoa is moving actively in either in a linear form or a circular form, and it crosses 25 micrometer of distance in a second. Slowly progressive motility, where again the spermatozoa is moving actively either in linear or larger circle, but the distance is from 5 micrometer to less than 25 micrometer. Non-progressive motility is all the patterns of active tail movement with an absence of progression. The sperm need not have to move further, or it is swimming in circles, flagella force displacing the head less than 5 micrometer from the starting point to the end point. Immotile is no active tail movement. The immotile sperms that is not a dead sperm. The most important aspect of analysis is finding the sperm morphology. The value of human sperm morphology assessment gives diagnostic information about the functional state of the male reproductive organs, primarily the testicle and the epididymis. Defective spermatogenesis and some epididymal pathologies are commonly associated with an increased percentage of spermatozoa with abnormal shape. When we do the morphology, you find most abnormal sperm. Definitely, it is indicating that there is some kind of defective spermatogenesis. Abnormal spermatozoa generally have lower fertilizing potential depending on the types of anomalies and may also have abnormal DNA. Morphological defects have been associated with increased DNA fragmentation. We all know that. An increased incidence of structural chromosomal aberrations, immature chromatin, and aneuploidy. It is important to evaluate specific morphology of head, midpiece, tail, and all the possible and the possible presence of abnormal cytoplasmic residual. The lower reference range of normal morphology is given as 4%. Any sperm with lower morphology then the reference value is called teratozoospermia. These are the major defects present in the sperm and we do morphological assessment. It is divided into head defects, neck and the midpiece defects, tail defects, and excess residual cytoplasm. In the head defect, it is tapered, elongated sperm, pyriform, no acrosome or small. In the small head, the acrosome is present, but the total size of this head itself is small. Amorphous, where you cannot actually define the shape of the head. Vacuolated, vacuoles present in the acrosomal region of the sperm head and the small acrosomal area. When it comes neck and midpiece defects, there are bent neck, asymmetrical, thick insertion, and thin insertion. Tail defects are short tails, which shows less motility. Bent tails, again, the motility is affected, and coil tails. The excess residual cytoplasm, which is more than 1/3 of the head size, is considered abnormal. It is again, this table shows what is normal and abnormal when it comes to morphological assessment. It says the head should be smooth, regular, and oval in shape. A well-defined chromosomal region, 40 to 70% of the head. The acrosomal region should not contain vacuoles, or it can contain two small vacuoles, but no vacuoles in the post-acrosomal region. The midpiece should be slender, regular, same length as the sperm head. Major axis of the midpiece should be aligned with the major axis of the sperm head. That means the tail insertion should be at the center. The principal piece, when it comes to tail, the principal piece should have a uniform caliber along the length. The length of the tail is 45 micrometer long, and it may be looped back itself, but there shouldn't be any sharp nick, which indicates that the flagellum is broken. Cytoplasmic residue should be less than 1/3 of the sperm head size. This is considered normal. If you find that the cytoplasmic residue, as we call cytoplasmic droplet, is bigger, then it is considered abnormal. Sperm motility is also one of the great factors, because the sperm motility differentiate between the dead sperm and the live sperm. Sperm viability, it refers to the percentage of live sperm in the semen sample. This is especially important to measure if the sperm motility is low or there is no motility, to differentiate between a live non-motile sperm and the dead sperm. The sperm motility is estimated by assessing the membrane integrity of the cell. The percentage of live spermatosoma is assessed by identifying those with an intact cell membrane by dye exclusion. The principle is the dead cells will have damaged plasma membrane, which will allow the sperm to take the stain, and they look dark. As you see in the picture, the live sperm is transparent and looks bright. The dead sperm takes the stain and it looks red. There is one more test which is used to test the sperm viability, is hypotonic swelling. The recommended test is eosin-nigrosin test, and the total vitality recommended by the WHO manual is 54%. The other test which used for the vitality test is hypoosmotic swelling test. It is an alternative to dye exclusion, because you cannot use this method when you are selecting the sperm for ICSI. So this is used when you have total immotile sperm, and then you have to do ICSI and choose the live sperm. This hypoosmotic swelling test comes handy. The hypoosmotic swelling test presumes that the only cells with intact membrane can swell in hypotonic solution. The swelling is within 5 minutes, and all flagellar shapes are stabilized by 30 minutes. So whenever you select the sperm for ICSI, you can actually pick out the sperm with the swelling. Sperm agglutination is again one of the microscopic evaluation you do. Agglutination is specifically refers to the motile spermatozoa sticking to one another. Either it can be head-to-head agglutination, tail-to-tail agglutination, or it can be in a mixed way. The motility is often vigorous with a frantic shaking motion when the heads are attached, but sometimes the spermatozoa are so agglutinated that their motion is completely limited or completely absent. The one advanced technique which is important in any semen analysis nowadays is sperm DNA fragmentation. So I'm going to talk a little about it. The sperm DNA damage can be defined as any chemical changes in the structure of DNA. Among these changes, sperm DNA fragmentation is one of the most common disturbances affecting the genetic material in the form of either single or double DNA strand breaks. Sperm DNA fragmentation may be triggered by different processes, including the defective package of the DNA during spermatogenesis, the process of cell death, and oxidative stress, which might cause due to the environmental condition or any kind of pathological condition. Although the fertilization capacity of the spermatozoa with high DNA fragments may not be impaired, but there are several researches which show that it will affect the embryo development, it will affect the implantation and pregnancies in both natural and assisted reproduction. The sperm DNA fragmentation is prevalent among men with abnormal ejaculate parameters, with low volume or with low count, bad morphology. And it has been proposed to be related to the cases of infertility in normozoospermic individuals. Even when the sperm looks good in sperm concentration or the motility, morphology, everything is fine, still the there is a male infertility. The sperm DNA fragmentation contributes to the fact that the person is infertile. An important addition in the work of male infertility, this fragmentation becoming one of the most discussed and promising biomarkers in the basic and clinical andrology. The sperm DNA fragmentation is a quality analysis, and this need not to be the part of the routine semen analysis. It can be performed when and where it is indicated. The DNA fragmentation is most frequent DNA anomaly present in the male gamete that has been associated to poor semen quality, low fertilization rate, impaired embryo quality, and pre-implantation development, and reduces clinical outcomes in assisted reproductive procedures. There are different methods which are there to evaluate the sperm DNA fragmentation. There's tunnel assay, comet assay, and sperm chromatin dispersion. Sperm chromatin dispersion is the most commonly used method to evaluate the sperm DNA fragmentation. This test is to evaluate the susceptibility of sperm DNA to acid denaturation. The sperm chromatin dispersion is based on the principle that the intact DNA loop expands following the denaturation and extraction of nuclear protein. Whereas when the DNA is fragmented, the DNA will not loop, and the dispersion is very minimal. This method relies on the capacity of the intact sperm chromatin to form dispersion halos. After being exposed to the acid and lysine solution, the halos correspond to the relaxed DNA loops attached to the residual nucleic structure. The less the DNA fragmentation, better the halo, which are released after the removal of nuclear protein. So the halos are classified as large, medium, small, without halo degraded. When there is no halo and you see a degraded head, that shows that this category is associated with severe damage of damage which is affecting both DNA and even the protein compound. This coming back to the reference ranges, there is a small table which shows the difference between the 5th WHO manual and the 6th WHO manual. The parameters are explained in semen volume, total sperm number, motility, vitality, and normal form. There is not much of difference. Now coming to the question, has sperm analysis lost its importance? I would say no. Even though we are not very much concentrating on the analysis, there are certain factors we have to consider, as Charu sir and Ved sir said. Yes, 6C for all reduces the importance of analysis because we just put a drop of sample and we see whether it can be used for IVF or ICSI. We don't analyze it. And even the ICSI for all, where ICSI, the most preferred technique is ICSI, you actually even not consider the concentration and the motility also. All we need is morphology. Even morphology is not good. Now we can actually select one good sperm among the other sperm, and we can do ICSI. So yes, in this case, some sperm analysis is not important, but then we cannot. This practice is not right. It means you can't apply ICSI for all. Advancement in techniques of retrieving sperm from the testis, even there is no, you see no sperm or less sperm. We have now so much advancement in the PISA say techniques that you can retrieve sperm from the testis directly and can be used. I mean, we definitely produce good embryos out of it. Better sperm preparation techniques with the low, you see there is little low count, but then we have max, we have microfluidics right now. So where we get good sperm recovery from the low count, low motility samples also. So you say, why do we have to do analysis when we actually can get good recovery from any kind of sample? So the better sperm preparation techniques probably yes contribute to this field. The non-standardized practice of semen analysis and reporting and lack of standardization, there is no single kind of analysis pattern followed. A person gets tested in 2 different labs, 3 different labs, he might get 3 different results. So the standardization is very less, and then you stop thinking that, okay, if they are not doing, why get it done? It's okay. I mean, we will go for one of the ART technique and then we get the pregnancy. So the major focus is on getting a patient couple pregnant, so than the treating the male infertility as such. But as I said, now the focus is shifting, and then the male infertility is treated rather than concentrating just to give a baby to the couple. So in conclusion, I would like to say that semen analysis is and always will be important diagnostic procedure in fertility treatment. The basic analysis and some extended analysis of semen sample could give important information about the male fertility and help to treat the infertile couple. It is important to standardize the analysis method and reporting pattern across all the labs so there are no confusions. A standardized semen analysis can prevent unnecessary treatment or ART procedures. This is very important. When you do a proper semen analysis, you actually can avoid so many, advanced procedures in the ART, or probably it's a simple treatment which can be given to the couple. So in conclusion, I would like to say, no, the semen analysis will never lose its importance. It's just that we have to understand and, understand the importance of it. And yes, the semen analysis has to be done every time a couple is coming for the ART treatment, or even if they are going for a spontaneous conception and they have a problem in conceiving. So the semen analysis is one step where you actually help the patient to evaluate themselves. Thank you so much.
Thank you, Jayalakshmi. It was very nice and very elaborate points, all very well taken. So I would like to ask you a few questions. By that time, is Nidhi, do we have any question there in this thing?
No, sir, we don't have it. So I think so.
Okay.
It's a very, very well said lecture.
Yes, yes. So what, Jayalakshmi, I just want to know, as a layman, suppose I am a junior embryologist and someone asks me, how will you ensure the fertilization? I don't know, there is an insistence of doing ICSI and ICSI, and what are the parameters one should consider while deciding that whether we can go for IVF or not? Because we know that even droplet culture is also there. If the count is low, we can do in a droplet IVF and all. So according to you, in your experience, what important parameters one should look for semen analysis to determine that whether it can be used for a normal IVF or there is no option rather than going for ICSI?
I would like to say that the choice of ICSI should be in a place where you have all the sperm parameters severely affected, that the count is low, the motility is pretty bad. Even count, I feel, if it is low, you can have pooled sample and then do the sperm preparation and get the count right. When the motility is quite poor, then you know that the sperm cannot swim. The morphology is pretty bad. I think apart from that, I don't think you should consider ICSI. ICSI is for the severely affected male infertility conditions. Otherwise, I think the IVF does good practice unless until they have a previous record of elongated the history where they have undergone too much of fertility treatment, IUI is done, or probably IVF is done.
In my experience, what I feel is that it is more of fear of failure fertilization. I think there is nothing consideration of count, motility, and other parameters. It is just that whether
what you have to answer the patient actually is more threatening for us.
So that's why some places at least they are doing 50-50. That is also still considerable that because I also believe in this, that natural selection is the best selection. So there was some question, other, or Nidhi, you want to ask some?
I'll just ask a question, ma'am. Like we talked about DNA fragmentation. So now, what is the time of intervention for a patient when you will bring DNA fragmentation as one of the tests or parameters, or should we do it for all? What should be the right way of approach?
I think, the answer might look funny. The first thing I feel is the cost factor here. Okay, if you can actually include the DNA fragmentation test in the package with a low cost, I think it can be offered to everyone. But otherwise, other than that, I think you should look for the history, any failed attempts, and then I guess then you can go for DNA fragmentation. Even the sperm is normal, or when you see the, as I said, that severely affected male factors, yes, you can do it in the first attempt itself. If there is normal sample where you don't actually, don't see any kind of problem with the sample, I don't think you should go for DNA fragmentation test in the first attempt. Again, that's what I said. It depends on the patient history, many failed attempts, or whether the sample is severely compromised. Other than that, I think there is no need.
Okay. So with this, thank you so much, ma'am. And let's, I hand over the session to Nancy. Can you take over, please?
I should stop sharing my...
yes, ma'am. Thank you so much, ma'am, for the wonderful presentation. We will carry forward. And all the procedures will be depicted to you in an elaborate manner now. Nancy, could you please take over? I'll just share the screen.
Yes. Okay. So after this wonderful session on why semen analysis is this important, let's move towards the next session of the evening, where we will get to know about every parameter of the semen analysis and why it is important. For the next session, we are having expert moderators and our speakers. Starting with the first set, we are having Dr. Hetal Shukla as a moderator. Sir is Chief Andrologist in Nova IVF Fertility. He is managing Andrology lab, doing structural trainings of new Androtechs, and he also worked as a reproduction biologist in management of nature conservation, Department of President Affairs, United Arab Emirates. And he also worked as a laboratory officer from 1996 to 2009 in Sabarmati Ashram Gaushala managed by National Dairy Development Board. So welcome, sir.
Thank you.
As a speaker for first session of microscopic examination, we are having Ankita Suthar. She's junior andrologist, Department of Reproductive Medicine, IKTRC Hospital. She's working in this lab from last 3 years. She's graduated in molecular microbiology from Gujarat University. So let's start with Ankita and understand what are the microscopic examinations we are having.
Just give me a second.
Good evening, everyone. Today we will be learning about semen analysis. I'll be taking care of color and volume. So the overall aim of the presentation is to describe laboratory methods of semen analysis. Before starting further, there are two most important things an andrologist should always recheck. First is the patient right of information, how he is going to collect the sample, how we are going to use it. And second one is ambient temperature for it. Type of container should be used and record of patient details on the container. This is the semen collection cup having the details of patient with AI barcode for identification. Now first we discuss about semen color. It is important to assess semen color and how the color of semen affect fertility. Semen color can change for many reasons. As we know already that clear white or gray semen is considered as the normal or healthy. Some minerals, proteins, hormones and enzymes also contribute in semen color, which is primarily responsible for this color, such as acid phosphatase, citric acid, zinc, sodium, potassium, calcium, and more. Temporary changes in color aren't cause of concern. Let's find out why semen color turn into dark yellow, red, green, and brown, and when to seek treatment. Now, pale yellow is usually normal, but what if a sample is dark yellow or greenish? It is usually associated with some medical condition like jaundice, prostate infection, urine in semen, leukocytospermia, taking some vitamins or drugs, and diet. Moving towards next color, red or pinkish color of semen is known as hematospermia. It is also associated with high blood pressure, prostate biopsy or surgery, prostate or testicular or urethral cancer, and also because of vigorous sex or masturbation. Sometimes color of semen turn into brown. Brownish or orange tinge is a sign of older blood shade. Very rarely, but sometimes color of semen is black. It is usually could be also because of hematospermia. It may be because of spinal cord injuries and heavy metals such as lead, manganese, and nickel. Now, when you deal with this color sperm, there is also possibility of male fertility problems. Many things you can do to improve sperm quality and return to the normal color, such as regularly exercise, balance zinc level, avoid stress, loss weight, etc. These problems generally aren't not serious and many will get better on their own without treatment or after a course of antibiotic or anti-inflammatory painkillers. These are some references I have taken for the color of semen. That's all for color. Now let's discuss about semen volume. Accurate measurement of volume is mandatory in the assessment of semen. It is necessary for the calculation of the total number of sperm, the total number of non-sperm cells in the ejaculate, and the total amount of biochemical markers. There are two different methods for measuring semen volume. First is volume by weight, and second is measure with pipette. Now the volume is best measured by weighing the sample in the container in which it has been collected. Use a pre-weigh container for the collection of ejaculate with noted weight. For grammatic measurement of semen sample, all collection cup may pre-weighed before being given to the patient. Empty containers have different weights, so individually each cup pre-weighted. Sterile containers should not and do not require opening for this. Now, second step is collection cup. Weigh the collection cup with semen in it. Now subtract the weight of empty container. Calculate the volume from the sample weight, assuming the density of semen to be 1 gram per ml. Now let's assume the weight of empty container is A and the weight of a container with sample is B. How do we calculate volume? You have subtract B minus E. Now second method is measure with pipette. Volumetric measurement can be done by taking sample from the container with the help of pipette and measure by putting it into conical tube or directly from the pipette. The volume measured by pipette will always be affected by a loss of 0.3 to 0.9 ml. There can also be unseen air bubbles inside pipette that can cause overestimation of volume. Some volume is lost inside in the pipette itself, which can cause difficulties for analysis of low volume sample. These are some references for method of volume. Now, semen volume has a minimal effect on sperm fertilizing potential. However, semen volume determination can aid in the identification of abnormal semen etiology by providing measurable parameters. The average volume of ejaculate can vary from person to person. Sometimes it's low in volume, it's called hypospermia. If it's some high in volume, it's called hyperspermia. Now, what is hypospermia? Hypospermia is a term that is used to indicate a decrease in semen volume produced by a man, where constantly produced in a low volume of semen when ejaculate, in which less than 1.5 ml of semen are produced per ejaculation. This can be caused by many conditions. Main cause of hypospermia is improper collection or loss of fraction, retrograde ejaculation, hypogonadism, obstruction of lower urinary tract, seminal vessel blockage, stress, and hormonal abnormalities. Now, hypospermia is a leading cause of male infertility. Depending on the cause of treatment, treatment of hypospermia is possible. It can involve a surgical procedure, medication, or changes in lifestyle habits. Now, next is what is hyperspermia? Hyperspermia is a condition in which a man produces a larger than a normal volume of semen. It is relatively rare than hypospermia and is generally defined when the volume is above 5.5 ml. It is found to be affected 4% of the male population in India. Main cause of hyperspermia is prolonged abstinence, use of steroid, excessive secretion from the accessory sex gland, and infection in prostate. If the hyperspermia is causing infertility issues, then approach for treatment, such as medicine to increase the semen count, sperm retrieval technique, use IVF or ICSI to achieve pregnancy. Some factors which influence the semen volume, such as age, sexual activity, genetic factors, lifestyle factors, overall health, and alcohol. These are some references I have taken for the volume of semen. That's all from my side. Thank you so much for listening to me. I just wanted to add that all aspects of ejaculate collection and examination must be assessed using properly standardized procedures if the results are to provide reliable information. Thank you.
Thank you.
Hital sir, you can take over, sir.
Yes, thank you, Ankita. A wonderful presentation from your side. Very good elaboration on color and volume and collection, and really good. I would like to say one or two things which she has said about volume measurement by weighing. Really, it is very recommended procedure, but practically probably slightly not feasible into the IVF clinics. But of course, when this weighing method is it is very much recommended, where the volume and total sperm count is very important. Like in veterinary side, you know, the total sperm count is very important when ultimately number of semen doses which is going to the field for artificial insemination is very important. And in that case, it total sperm count is it makes a lot of difference with the multiplication of volume and the sperm concentration. So definitely, yes, volume measurement is very important, most precise as far as it is required. So whenever means end research, when the samples are processed for the research purpose, there also this volume measurement becomes a very important, very precise one should be there. And that time when you are taking this volume measurement by weighing, then normally semen density is observed between 1.020 to 1.040 grams per liter, right? So we have assumed that yes, fine, 1.0 in our purpose it can be good. Yes, it can be a thought of the fine. Really good. Any question from the audience, or are we going to take it? It can be there. Fine.
Yes, sir. There is a question from audience that they are asking if the semen volume is less than 1.4 ml, but other parameters are absolutely normal. What would be the impression of semen analysis?
Yes. So see, this semen volume is directly, it can be directly affected by the certain collection issues also, and that has to be counseled, that has to be discussed with the patient, and then only you can come to know. So if you find lower volume and higher concentration, or higher concentration lower volume, any combination will be there when you receive the sample inside the laboratory, fine. But you have to find out what could be the possibility and certain collection issue that will definitely play a role, because patients, many a times patients are not comfortable in producing the sample at the site of collection, or the type of method he is opting for, and this one can find with the counseling or the interaction with the patient. You make him ease, and if he has certain myths, you can just relax him, or somehow. So with that, yes, but this is very much possible. 0.5 milliliter or less than that volume will yield many millions, maybe 70, 80, 90, 100 plus million also concentration will be there. That is very much likely possible. And in that case, what one should take care is, this kind of sample you cannot leave for a long for analysis, liquefaction or something, because volume is very less, sample will start getting dried out, and that needs to be taken care immediately by adding some culture media, some into it, make it 1 milliliter, so that you, and please make sure whatever amount of culture media you are adding at this, in this kind of cases, you make sure the amount you are adding, so that at least you can come to the conclusion that what is the real sperm concentration available in the sample. So I think this kind of things, with that impression, one should also please take care with the sample handling and all. And especially many times, when collection issue, when we are addressing, and if patient is allowed to bring the sample from the home, then also collection container needs to be given. Husband, wife both should report to the place. Undertaking should be taken. This kind of things one must take care. The belongingness of the sample must be taken there. So this kind of things must be taken care, and they should not allow the sample for a variation of the temperature during the transport. So proper transportation, these kind of instructions also needs to be given to the patient if they are bringing it from the home. I think this information will help everyone for taking care of the lower volume, higher volume, anything.
True, sir. Thank you so much, sir. Thank you, Ankita, for the wonderful presentation, and thank you, sir, for concluding so well. Now, for the next speaker for the evening is Kajal Patel. Kajal Patel is junior embryologist in Department of Reproductive Medicine, IKDRC Hospital. She is working in the field from last 6 years, postgraduate in biotechnology, and she has done her training from embryology, Origio Embryology Training School, Mumbai. Over to Kajal. She'll be showing us the microscopic techniques like liquefaction and viscosity.
Good evening, everyone. Today we will learn about semen analysis. So we have already discussed about volume and color. Now moving further towards semen analysis. Semen analysis is divided into two categories. Micro and macroscopic examination. Here I am talking about macroscopic examination. I will be taking care of liquefaction, viscosity and pH. Here is our learning objectives. First one is what is liquefaction, viscosity and pH. Other is methods to resolve liquefaction and viscosity. And last, effect of hyperviscosity in semen samples. Let's start with liquefaction. Liquefaction, what is liquefaction? Liquefaction is becoming thinner. So what happens after ejaculation into the collection vessel? The ejaculate is a semi-solid coagulated mass or a jelly-like clump. Mostly the sample begins to liquefy within a few minutes at room temperature. As liquefaction continues, the ejaculate becomes more homogeneous and more watery, but still with a higher viscosity than water. This is the image of coagulated sample. Complete liquefaction is normally achieved within 15 to 30 minutes at room temperature. If liquefaction is not complete within 30 minutes, samples should be left for another 30 minutes. If liquefaction is not complete within 60 minutes, it should be also reported and noted in the final report of the patient. A temperature of 37 degrees will facilitate liquefaction. Also, a slow swirling movement of the sample container will help to complete liquefaction. Here is the video of swirling movement. So, sometimes the sample may have contained a few jelly-like granules or gelatinous bodies which do not liquefy and do not appear to have clinical significance. Here is the image of gelatinous bodies which settle down at the end of the tube. We have to take all amount of sample in centrifuge tube. Gelatinous bodies will settle down at the end portion of the tube and use only supernatant of the sample for IVF and ICSI procedure. Now moving towards viscosity. After liquefaction, the viscosity of the ejaculate can be estimated by gently aspirating it into a white-board plastic disposable pipette, which is sterile, allowing the semen to drop by gravity and observing length of any thread. In normal sample, liquefied falls as small discrete drops. Anything which gives you more than 2 centimeter threads is abnormal sample. This is the image what happens when you prepare a highly viscous sample by density gradient technique. Now moving towards types of viscosity. Viscosity is divided into 4 categories: normal, minimal, increased and grossly increased. In normal sample, where we observe discrete drops or less than 2 centimeter threads with the pipette. Second one is minimal increased sample. If threads are 2 to 4 centimeter longer. Third one is increased if threads are 4 to 8 centimeter longer. In grossly increased if we observe the threads more than 8 centimeter long. Here is the video of how to check viscosity with pipette. This is the image of minimally increased sample. Second one is increased sample. This one is grossly increased sample. Now moving towards how to measure viscosity. Here is another method to check viscosity. Alternatively, viscosity can be evaluated by introducing a glass rod into the sample and observing the length of the thread that forms upon withdrawal of the rod. In unliquefied sample, exhibits homogeneous stickiness and its consistency will not change with time. High viscosity can hinder proper assessment of sperm motility and concentration. If sample is not liquefied within 60 minutes, sample is viscous. How to resolve viscosity? There are 4 methods to resolve viscosity: mechanical mixing, dilution of medium, use needle and syringe, and use of proteolytic enzyme. Occasionally, the samples may not liquefy. In these cases, additional treatment of mechanical mixing may allow further assessment. This will affect the seminal plasma, sperm motility, and morphology, and their use must be reported. Second one is dilution of medium. In this case, the addition of equal amount of physiological medium followed by repeated gentle pipetting should be done. Third one is use of 18 or 19 number gauge needle and syringe for break viscosity. However, this is not recommended since the sharing of forces are likely to damage spermatozoa and thereby negatively affect the DNA integrity. Fourth one is proteolytic enzyme. A broad specificity proteolytic enzyme may help to promote liquefaction, but will affect both biochemical markers and sperm motility. These are some studies which supports our discussion. Seminal hyperviscosity is associated with poor outcome of in vitro fertilization and embryo transfer. This is our study. Effect of some semen hyperviscosity on blastocyst formation rate and implantation rate. This is the result. Lower implantation rate and clinical pregnancy rates in couples with seminal hyperviscosity may be attributed to biophysical alterations or chemical changes of the ejaculate that could impact sperm DNA despite the presence of apparently normal motile sperm for the IVF or ICSI procedure. Now moving towards about pH. What is pH? pH is a scale used to specify how acidic or basic or alkaline a water-based solution is. Acids are defined as substances that increase H+ ion concentration and bases as substances that decrease H+ ion concentration. If pH is greater than 7, indicate base. If pH is less than 7, indicate acid. If pH is 7, being neutral. Here is the image of pH strips. The range of, between 1 to 14. So, the pH at ejaculation depends on the relative contribution of acidic prostatic secretion and alkaline vesicle secretion. In the ejaculate, there is no efficient control of pH of the fluid. In vitro, there will be a continuous loss of CO2 that causes a gradual increase in pH. If pH is to be assessed, it should be done within 30 minutes after collection. In any case, within 1 hour of collection. Normal range of the semen sample is 7.2 to 8. But what if pH less than 7 and ejaculate without spermatozoa? There may be a congenital bilateral absence of the vas difference. Seminal vesicle may also be missing or poorly developed, causing a low volume and low pH. We can do it by 2 methods, either by strips or by use of pH meter. How to measure pH of a sample? Mix the semen sample well. Put a drop of semen on the pH strip. Wait for color change. Within 30 seconds, compare the color with the calibration strip of pH. A pH value under 7.2 may be indicate of lack of alkaline seminal vesicular fluid. It can also be due to urine contamination. These are the things which we required for pH test of semen sample. Firstly, we have to label the pH strip with appropriate patient's ID. On litmus paper. Place 20 microliter of semen sample, liquefied and well mixed sample on litmus paper. Observe the color from 30 to 35 seconds. Compare the color with the provided strip chart. For viscous sample, pH can be measured by pH meter. Of a small aliquot of the ejaculate can be measured by using a pH meter, which is designed for measurement of viscous solutions. This is the image of pH meter. There are some reference which supports our discussion. Semen pH and its correlation with motility and count. Semen pH affects sperm motility and capacitation. This is the results. There were correlation between seminal pH and two important fertility parameters, motility and count, indicating that the semen buffering system plays a vital role in maintaining the overall seminal quality, which is of clinical relevance. The end, concluding with the aim of the semen analysis is describe laboratory methods for examination of ejaculate to contribute to global improvement in assessment of male reproductive function and treatment of male factors of fertility. Thank you so much for your time and patience. Thank you.
Okay, thank you, Kajal. Really good presentation covering all the aspects of the viscosity, liquefaction, and pH. Almost all the aspects are covered by you. Really good. Some extra things which I would like to add about pH is, sometimes pH goes towards alkaline. Maybe it's not, it will hardly be more than 8, but, and it will not be a big concern. But yes, of course, if the pH is towards acidic, then it is even slightest change, around less than 6, if it goes between 5.5 to 6, then also it will be a big concern. And sometimes probability of retrograde ejaculate, where pH will matter a lot because of the acidic nature of the urine, which is very much possible. And that time also alkalinization of the patient by giving some syrups or some treatment is also very much important. So really that should be taken care by the collection team and the clinical team also. Any other question or anything to this?
So we are having one question in question answer session, that
Yes.
Is it normal to get a pH of 8.5 to 9?
Means if you get the pH more than 8.5.
Yes.
I think it's not normal. But yes, when you get this kind of scenario, then try to compensate it or balance it with the culture media immediately. So upon the liquefaction, immediately firstly affect, it will definitely increase the ROS production, and it will adversely affect even DNA integrity as well. So it should be very much critical about, one should be very critical on that.
Okay. So there's one more question, that what is the cause of hyperviscosity?
Cause of hyperviscosity is, I would say it is probably the secretion of accessory sexual glands, and that plays the the prokinase like enzymes are also there in the semen, and if so if certain uh, secretion is absent, maybe high viscosity will be a cause of the sample.
Maybe I can add one more thing. Sometime what happened, there is some infection in that accessory glands or somewhere there in the tract.
Yeah.
So it may be the cause of the hyperviscosity. So we have to take care about that also part, that at that time one should go for semen culture also to rule out the infection. Because of infection, there may be some inflammation, and that secretion may be affected by this.
Correct. Very true.
So I think it's done for this session. Now moving towards the microscopic examinations. Dr. Nidhi, can we have the slides? Dr. Nidhi? So now moving towards the microscopic examinations, we are having Dr. Paresh Makwana as moderator. Sir is ASRM certified embryologist and chief embryologist in Wings group of hospitals, Ahmedabad. Sir is an executive committee member of ACE, lifetime member of IFS, treasurer in IFS Gujarat chapter, lifetime member of Fertility Preservation Society, and also member of IHERA and ASRM. Sir, the key areas of interest of Sir, Dr. Nidhi, are, I'm so sorry, expert in blastocyst embryo biopsy, blastocyst biopsy, oocyte and blastocyst vitrification, in vitro maturation in oocyte. Welcome, sir. Now, for the first session, we are having Deepu Gupta. He's MSc in biotechnology, senior embryologist at South End Fertility and IVF for Sandhya, New Delhi. So having more than 10 years of experience in the field of ART. He's trained in IVF and ICSI. He is a member of ACE and team member of IHERA. Can we start with the presentation of Deepu?
Good evening, everyone. Thank you, IHERA, for this opportunity. Today, my topic is sperm count in semen analysis. So, what is sperm count? Sperm count is an important parameter of semen analysis for considering the child. A normal sperm count range in WHO manual is 15 million per ml of semen. Anything less than 60 million per ml is considered as a low sperm. It is an important aspect of semen quality with the number of concentration of sperm cell in a amount of semen. Sperm concentration refers to the number of spermatozoa per unit volume of semen. Total sperm number refers to the total number of spermatozoa in the entire ejaculate, and it is obtained by multiplying the sperm concentration by the semen volume. In addition, to achieve the correct volume in the counting chamber, the counting must be properly tight and the counting chamber must be correctly filled. So there are 4 methods for sperm count. The first one is hemocytometer, the second one is macro chamber, third one is wet mount, the last slide and cover slip, and the fourth one is LVU chamber. So first discuss about the newborn chamber. The use of hemocytometer chamber with improved newborn ruling is recommended. The improved newborn hemocytometer has a 2 separate counting chambers, each of which has a microscopic 3 mm into 3 mm pattern of grid attached on the glass surface. So now the procedure. Always allows sample to liquefy and mix well before analyze the sample. Fill the sperm dilution fluid into a tube to 380 microliter and add 20 microliter of semen on the tube. Wait for 5 minutes, add 10 microliter of mixture of semen and dilution fluid into the chamber. Put cover slip on the chamber, count in 20x magnification on microscope, count the number of spermatozoa in an area of 2 square mm. Now the second one is Mackler chamber. The Mackler chamber was designed especially for the determination of sperm concentration and motility in undiluted semen. It has reported depth of 0.01 micrometer. The grid area of the entire of cover slip is 1 mm into 1 mm and is divided into 100 small squares, each of which is 0.1 mm into 0.1 mm. Now the procedure is mix the specimen well and take care to avoid formation of bubbles. Add 10 microliter of semen suspension while loading into the center of chamber and the sperm counted. Lift the chamber by its handle and place into the stage of the microscope. Total number of sperm in 10 square is equal to count in million of per ml. The Mackler counting chamber is quickly and easily available for reuse. The third one is wet mount preparation, that is glass slide and cover slip. Counting in a glass slide and cover slip is the simplest method for calculating concentration of spermatozoa through wet preparation with chamber depth of approximately 20 micrometer deep. Procedure: mix the semen sample well, add 10 microliter of semen, put on the glass slide and cover with cover slip. Observe the glass slide under phase contrast microscope. Take care to avoid air bubble formation between the cover slip and the glass slide. Access the freshly wet preparation as soon as possible. Count in 40x magnification under the compound microscope. And the last one is cell VU chamber. The cell VU pump counting method involves the use of dual chamber glass slide and a two piece of 0.5 mm thick cover slip containing a laser attached clip on the reverse slide. The grid area is 1 mm into 1 mm and divided into 100 smaller squares. The chamber has reported depth of 20 micrometer. Procedure: a 4 microliter of volume of semen suspension was loaded into the left and right chamber. The number of sperm counted based on those sperm mixed at the upper and left side is the lower and the right side of each pair of counting chambers. To ensure consist counting, a minimum of 200 sperm were counted in each chamber. So, when no sperm seen, prepare semen sample in centrifuge tube with hyposomia in the ratio of 1:1 and centrifuge at 1500 rpm for 10 minutes. After centrifugation, discard supernatant and concentrate semen volume into a small pellet to check the presence of motile and non-motile spermatozoa in the pellet on the chamber or a glass head or a instrument. If azoospermia found, repeat semen analysis for the confirmation. These are the advantages of all counting chambers. The hemocytometer method is recommended by the WHO manual as the current gold standard for assessing semen concentration. The Mackler chamber provides the highest sperm count compared with the hemocytometer and cell VU method on sperm sample. It was designed specially for undiluted semen and has been used in many laboratories. Glass slide and cover slip method is the simplest method for counting in pathology lab. This can also for assess for infectious sample. The cell we use sperm counting chamber with its disposable has a unique advantage over other methods, especially for highly infectious semen samples. These are the nomenclature of sperm count. Azoospermia means no spermicide or eospermia, very low sperm count, and polyzoospermia may reach high concentration, 30 million per ejaculation. Causes of decreased sperm concentration are drinking alcohol, smoking, vasectomy, varicocele, primary and secondary testicular failure, endocrine process. So, how to increase sperm count? Lifestyle modification, medicine, regular exercise, relax, and minimize the stress, adequate slave, limit of alcohol intake, and lost body weight. This is the WHO sixth edition reference limit. The sperm concentration in per ml is 16 and the total sperm number per ejaculate is 39 million per ml. 39 million total. These are the two references. The first one is WHO manual, sixth edition, and the second one is a paper. In paper, they show three sperm counting methods for the determination of sperm concentration. So now I am starting my video presentation of all methods. So firstly introduce newborn hemocytometer and put 280 microliter spermatozoa dilution fluid into a tube and mix 20 microliter of semen when liquefied on the tube and wait for 5 minutes. After that, add 10 microliter of semen and then refrigerated mixture on the newborn chamber and count on compound microscope. You can see there is no live sperm due to the dilution fluid. Only that sperm is there. Now the second method, that is macula chamber. This is the macula chamber. Open the cover slip of macula chamber and add 10 microliter of semen on the center of macula chamber and put cover slip over it and gently put on compound microscope under 10x objective. Count 10 squares out of 100 and the last one is glass slide cover slip method. Put a glass slide on the same surface and add 10 microliter of semen and put cover slip and count in 40x objective under compound microscope. You see there is live and dead sperm. Thank you.
Thank you, Deepu, for the nice video presentation and elaborating the video presentation of the different method of the sperm counting. In the beginning of the webinar, the waiters already told that we are really losing interest on the sperm analysis. Yeah, it may be true because nowadays what we are doing ICSI, IMSI, so single sperm is required for the ICSI. And again, if you agiospermia, we do TESA, TSA, and do the ICSI. So somewhat we are losing some interest, but actually that is not good. So very much necessary the perfect semen analysis. When we are talking about the sperm concentration, I just would like to elaborate at explain whenever we do semen analysis, we have to ask or we have to take the history from the patient, because we had just experienced the patient was gone under IUI
from another center, and when we do it our center, the patient was the azoospermia. But it doesn't mean that we cannot blame the other center. But again, what we have to do, we have to take the history. There may be some spillage, or sometimes that patient is not able to collect the sample properly. So what we have to do, we have to take the sample for the 2 or 3 times and take the average of the sample, and we can proceed with the semen analysis. Here, when we are talking about the counting sperm concentration, they are a different method. But according to the WHO, the gold standard method is the Newbar counting chamber method. But most of the people they are doing the Mechler counting chamber method, because the Mechler counting is we can use in a non-diluted sample and with the in a non-diluted sample, and it's easy to use. But the limitation of that method is it's not accurate all the time, because it's vary from person to person, vary from collection to collection. In Newbar counting chamber, when we use a dilution factor, it's immobilize or kill the spermatozoa. So it will be easy for us to count the spermatozoa in Newbar counting chamber. So again, thank you, Deepu, for the nice presentation. And do you have any question?
Yes, sir. We are having a few questions. The first one is it okay to count the sperm in wet preparation as a beginner? Does it create any variation?
Yeah, I will regularly advise that when you are a beginner, go with the method which is really described in the WHO, like Newbar counting chamber or Mechler counting chamber. When you do the Mechler counting chamber, if you are using the Mechler counting chamber, you can compare your result with the Mechler counting chamber and your wet preparation method, and steply just gradually you can move towards the wet preparation method. So for the beginner, I will not advise to go for the wet preparation method.
This is, sir, there is one more question. When doing analysis using glass light, the number of sperms we count in 400x magnification, is it equal to million per ml?
Yeah, that is the wet preparation method actually. But again, it required experience.
True, sir. True. Thank you, sir. Now handing over to Yoshita.
Thank you, Nancy. Can you please share your slides?
Just a minute. Just a minute.
Okay, now let's forward to our next lecture. I welcome Ms. Farhad Ayub Khan. She has done his MSc in biotechnology and certification from Kasturba Medical College. And she is an embryologist in 49 Fertility Hospital, Hyderabad. So welcome, Farhad.
Hello, everyone. Good evening. My name is Farhad Ayub Khan, and I work as an embryologist at 49 Hospital. My topic is sperm motility assessment. As my colleagues have already discussed about the microscopic and macroscopic parameters, I'll continue with microscopic sperm motility parameter. For microscopic parameters for semen analysis, 4 major parameters are considered: sperm motility, sperm concentration, morphology, and leukocytes. For natural fertilization or fertilization, sperm motility plays an important role for a successful fertilization. It is regulated by cyclic AMP activated protein kinase A. As we know, tail of the sperm contains flagella, which have flagellar proteins like enexamal dynein, which propels in order so that the sperm can move in forward direction. Flagellar proteins always moves in forward direction. Sperm motility is an important and a good indicator for a good and a normal sperm. As the revised guidelines of WHO 2020, the total motility is increased to 42%, and progressive motility is now more than 30% is the requirement. For sperm motility assessment, we'll take 10 microliter droplet on the counting chamber like McClass chamber or on the glass slide, and we'll count 200 total sperm as the whole sperm in different fields, so that our assessment is precise and good. So then we can check the motility and count at the same time. According to the grading of the motility, it is divided into 4 categories. That is rapidly progressive, slowly progressive, non-progressive, and immotile. For rapidly progressive, the sperm moves actively in a linear motion or in a large circle. It moves with more than speed of 25 micrometers per second. As we can see, the motility is so fast that it is difficult to know that the sperm is moving from one block to another block. So rapidly it is moving. The second we have is slow progressive. In slow progressive, the sperm moves actively, either in a linear or a large circle. They are able to move with a speed of 25 micrometers, less than 25 micrometers per second. So as we can see, their motility can be visualized. Their motility is visualized, and we can easily predict it moving from one block to another block. The third is non-progressive. In non-progressive category, we have the movement, the sperms move in more rapid, more in a motion less than 5 micrometers per second. So they have movement, but there is no displacement in their movement. And then we have immotile. In immotile movements, there are no motility is found. It is assumed that they are not moving, but maybe they can be moving. That later on we'll check with the vitality test. So these were the 4 major categories of the sperm motility: rapid progressive, slow progressive, non-progressive, and immotile. There are various conditions very much considered while we are going for semen analysis assessment. The 4 things which are considered is that it is always preferable to take 2 replicas of the sample so that we can have a precise and an accurate reading. And the edges of the corners of the block is not considered. The sperms on the edges of the block are not considered. And velocity of the motile spermatozoa is temperature dependent. So it is preferable, and it should be done that the motility of the sperm depends on the temperature. So the body temp, it should be maintained at 37 degrees Celsius, that is body temperature. Further moving on, we have asthenozoospermia. It is a condition which is nowadays more seen in the patients. That according to WHO 2020 revised guidelines, progressive motility, if it is less than 30%, it is considered to be asthenozoospermia. Along with asthenozoospermia, we have like defects with others also, oligozoospermia and tetrazoospermia. Mostly 20% of the patients have isolated asthenozoospermia. As we can see in this slide, that the patient is suffering from absolute asthenozoospermia. There is no movement seen in the sperms. Asthenozoospermia is basically like we can go, the steps are followed if we find that it is absolute asthenozoospermia. We can go for a second sample collection, and then we can go again for the diagnosis. And if again the 100% immotile sperm is considered, then we can still, asthenozoospermia is divided into 3 categories. That is moderate asthenozoospermia, severe asthenozoospermia, and absolute asthenozoospermia. In moderate asthenozoospermia, it is the motility is less than 42%. In severe asthenozoospermia, few sperms can be seen motile in different fields. And in absolute asthenozoospermia, it is considered as 100% immotile sperms. In complete asthenozoospermia, we have to see the confirmation. So first we should confirm the sample by checking it and collecting the second sample. repeat semen analysis should be done. So if still 100% immotile is there, we can go for vitality test. If in vitality test, all 100% sperms are dead, that condition is necrozoospermia. In that condition, TESA or TESI is performed for ICSI. And if we find viable sperms, in the second condition, if we find the viable sperms, we can check for the infection. It can be the various infection or prolonged diseases. So the medication can be followed. So if we can do vitality test either by using Hoss test or using negrosine staining test. If we have seen there is some stimulation in the immotile sperm, pentoxyphylline can be used. In this, the viable sperm will start showing some movement after the stimulation. So various causes of asthenozoospermia is hormone imbalance, genetics, smoking, alcoholism, nutrition deficiencies, sperm antibodies, varicocele, sperm production problems, and various others. These can be recovered by using treatments such as properly following a healthy lifestyle, medicines, and having a proper diet. So thank you. That was for all for sperm motility assessment. Thank you and have a great evening.
Thank you, Farhat, for a nice presentation. You covered all the things actually for the motility. But I would like to add one thing here. Whenever you are checking for the motility, you have to consider a temperature because the velocity of the spermatozoa directly related to the temperature of the lab. So in WHO manual, what they are telling that you have to do the sperm analysis or sperm motility check at the temperature of the 37, not at the room temperature. Because why? Because the room temperature is different at a different time. So there will be a very high variation between your sample to sample. So you have to check the motility or concentration mostly at the 37 degrees Celsius temperature. That's why your temperature, your microscope and the state should be around the 37 degrees Celsius temperature. And there are many factors which are affecting the motility of the spermatozoa, like patient's age and general health, infections, length of the time since the last ejaculations, and patient's exposure to the outside influence like excessive heat or toxins, and method of collection. These all the things, they are actually affecting the motility. So at different time you have for the same patient, there's a different motility, and again it's vary from person to person. Maybe you have any question?
Yes, sir. We have 3 questions. First, if we are following 6th edition WHO, according to that, if motility is less than 40% of motility, then vitality is required. Then if it is less than 54% of viable sperm, then what will be the impression?
The motility is less than 40%, then it's asthenozoospermia. We all know the terms. But at that time, what we have to consider, total volume of the sample. But what we do when the motility is very low at our center and the volume is around 2 ml, 3 ml, then that is enough for our next procedure. But again, we have to consider that either we are going for the IUI, IVF, or ICSI.
So next question is a laboratory report of 0% motility and 100% non-motile count. Is there still a need to do a total count of the same semen sample?
Yeah, definitely, because both the parameters are different. So we have to do this total count. Because when we do the vitality test for this 0% motility, then it will help us to consider the sample for the ICSI, because we do the HOS or some laser method and we can use that sample. So definitely both are the different parameters. So we must have to do.
So one more question is there. Does progressive motility 30% mean grade A plus grade B sperm as per WHO?
As per WHO, progressive motility is a grade A.
Okay, sir. Last question is how to calculate non-progressive motile when concentration is high?
When the concentration is high, but when we are using the metal counting chamber, the depth is same. Okay, so we have to consider the progressive motility and the non-motile spermatozoa in the same. We know that when the concentration high, we are not going to count the 100 boxes. So we will count only 10 boxes, and we have to use the separate. We have to just by focusing and separate method, we can check the motility.
So one more question. Can you please explain the use of pentoxyphylline?
Pentoxyphylline is mostly useful during our TESA or surgical sperm retrieval. What happens when we are using the TESA sample? Mostly the spermatozoa are immotile. They are not dead, but they are immotile. So when we culture those the samples after just teasing the tissue and culturing for 1 or 2 hours, you will have some twitching movement in the spermatozoa, and that will help us to do the ICSI or the further procedure.
Thank you, sir. Thank you.
Thank you so much.
Thank you, sir. Thank you, Deepu. Thank you, Farhad. Now let's move on to next lecture. I welcome Dr. Charulata Joshi. He's a post-graduation in life science, and he's a medical director in Genes India ART Bank. He's a past vice president in ACE and past president in ACE. And sir is also a co-founder of iHera Society. Welcome you, sir.
Thank you.
Now let's welcome Dr. Rohit Bansal, who is the next speaker. He is an embryologist in CIFR Gurgaon. He is a ASRM certified embryologist. He has done his PhD in AIMS New Delhi, has various publications to his credit, and he has done his DC diploma in clinical embryology. Welcome, Dr. Rohit.
Good evening, everyone. I am Dr. Rohit Bansal. First of all, I would like to thank iHera Academy, Dr. Peter Kasser, Dr. Sanjay Shukla sir, Dr. Charulata Joshi sir, Dr. Nidhi to provide me this wonderful opportunity to speak about sperm morphology. Sperm morphology is one of the most important parameters to determine the functional potential of sperm. This is the structure of normal human sperm, which has an overall length of 50 to 60 micrometer. It is divided into 4 pieces: head, neck, midpiece, and tail. The head is further divided into two portions, the acrosomal region and the post-acrosomal region, and both of these regions should not contain any vacuoles or may have not more than 2 vacuoles. The neck region generally have a cytoplasmic droplet, which generally dried off during the staining procedure, but if it is there and the size of this cytoplasmic droplet is more than 1/3 of the head size, then it will be considered as residual cytoplasmic droplet and it will be an abnormality in the human sperm. The tail is thinner than the midpiece, and the tail should not contain any angulation on the band or coil, and the major axis of head, neck, midpiece, and tail should align in the same plane. Normal or nowadays ideal or typical is most recommended word. The normal or ideal, typical is ideal and typical is more recommended because the word normal is causing misunderstanding, which means cell does not have any disease. But the normal morphology does not mean that the sperm have no other cause of pathology, for example, immotile tail or the damaged DNA. So the ideal or typical sperm morphology provide diagnostic information about the functional state of the male reproductive organs, mainly testicles and epidermis. It reflects the normality of the spermiogenesis. It only relates to the sperm's functional potential and does not equate to sperm fertility, fertilizing ability, and the man's fertility. This is how the evolution takes place in interpretation of sperm morphology. In the WHO 2, which was published in 1987, recommends the cutoff value of 50% for the normal form. But after coming the type of strict criteria in 1991, the value of normal morphology value declines in consecutive WHO manual. Now it is around, it is more than or equal to 4%. The type of bug strict criteria is strict about smear preparation technique, staining technique, and the method of morphology variation. And they are also strict about the normal variation in sperm morphology. Every sperm in normal borderline will considered as an abnormal sperm. Now, these are some sperm abnormalities based on this Steiberberg strict criteria. They can be in head, neck, midpiece, tail, and excess residual plasm. In the head, they can be tapered, pyriform, round, having no acrosome or small, amorphous. They may contain large number of vacuoles. They have small acrosomal region. The neck may be bent, asymmetrical, thin and thin. The tail may be short, bent, and coiled. Similarly, on the basis of literature, the morphological defects has been associated with increased DNA fragmentation and increased incidence of structural chromosomal aberrations, immature chromatin, and aneuploidy. There are different techniques which are used for assessment of sperm morphology, like scanning electron microscope, SEM. AFM is atomic force microscopy, TEM is transmission electron microscope, and confocal laser microscopy. All these have very, very high resolution up to nanometer scale, but these techniques require a lot of expertization and they are quite expensive. They generally recommended in the academic or the research area. So, and they are not possible in the clinical setup. So in case of clinical setups, the bright field microscope is the only option. So there are different staining solutions like Pepinoplo, short stain, H&E stain, Ginsa, Spermex, Sperm Blue, and Diffquid. So we should take some precaution during the selection of stain. In ideal staining method, the stained spermatozoa should have dimension close to the spermatozoa in fresh semen. There should not any change in the morphometric dimension of sperm head, and the staining solution should be isotonic with the semen osmolality, because if there is a change in the semen osmolality, it will change the sperm cell volume due to activation of volume regulating mechanisms. So, according to WHO 2020, the papilloma is most recommended staining technique because it helps in sperm evolution based on Teiberberg strict criteria. It gives the overall visibility of all region of human spermatozoa, like acrosomal, post-acrosomal region, extra residual cytoplasm, midpiece, and principal piece. It also enables us to distinguish between the immature germ cells and non-sperm cells. It can be used for the quality control programs. If it is stored in dark place, the slides can be stored for the months or the years. In order to determine the percentage of spermatozoa with normal morphology, we have to assess all the spermatozoa in each field moving from one microscopic field to another. Assess only intact spermatozoa having head and tail. We do not include any immature cell in the sperm count. We do not assess any overlapping spermatozoa field. We have to evaluate 200 spermatozoa to achieve the low sampling error. We have to tally all the normal spermatozoa and abnormalities in the 4 region with the aid of laboratory counter. If there is spermatozoa head without tail, which is generally called pinheads, they should be reported if they are more than 20 per 100 spermatozoa. This is a small video showing how the morphology of the semen sample done in clinical labs. So, first of all, we have to label the slide. Then, preparation of smear of semen sample by adding liquefied semen sample, generally 10 to 20 microliter, but it depends upon the manufacturer protocol as well. Then mount the slide with cover slip and wait for some time for air drying, which fix and stain the slide. And then observe the slide in 100x lens with immersion oil. So this is the procedure how we generally done routine micromorphology in labs. So by using this technique, we can determine 3 indices from the reports of detailed abnormalities of the headpiece, mid, and principal piece in multi-entity system. These 3 indices are TZI, tetrazoospermia index, multiple anomaly index, and sperm deformity index. The TZI is most commonly used, and it is calculated by the it can be calculated by maximum of 4 defects, 1 from each head, mid-piece, principal axis, and axis residual cytoplasm per spermatozoa, and divided by total number of abnormal spermatozoa. It has a value of 1 to 4, and the value should be reported in up to 2 decimals. Now, what literature say about the importance of sperm morphology? So this is a paper which was published in 2018. They investigate the correlation between the sperm morphology and the incidence of embryo aneuploidy in oocyte donation program. So they result that there is no significant difference in the fertilization rate, and they also suggested that the diminished sperm quality is correlated to aneuploidy rate in pre-implantation embryos. The next study is in Asian Journal of Andrology in 2021. This study also find the correlation between the sperm morphology and the pregnancy outcome and offspring in vitro fertilization. So they concluded that the couples with tetrazoospermia had significant lower optimum embryo rate compared to those with normal sperm morphology. Further, there is no increase in the risk of birth defect occurred in the tetrazoospermia group after IVF-ICSI. They also believe that tetrazoospermia has limited predictive value for pregnancy outcome in IVF and ICSI and has a little impact on the resulting offspring if multiple pregnancies are avoided. The take-home message: sperms are one of the most highly differentiated cell in the human body. Small heads are usually hypohaploid. Large head sperms are typically diploid. Strict criteria has good predictive value for in vitro fertilization outcome. Ideal or typical sperm morphology visualized by the light microscope is not same as functional competence. Thank you very much.
Thank you, Dr. Rohit. It's a good presentation. Do we have any question to ask, or should I?
So we have one question.
Yeah.
Practically, as per your experience, how important is morphology?
Morphology, very, very, very important, one can say, because till today it is a question many times comes in front of us that even performing after ICSI, still there is no fertilization. So probably you have to find out the answer that even if ICSI is done, still there is no fertilization. So morphology may be one of the criteria, because nowadays what is in practice is that you just see the movement. If the sperm is moving, that means it is alive and it's a good sperm, and you just inject. So morphology from beginning is a very important criteria in selecting of sperm. And that's why I always insist that one should have detailed in-depth analysis, as we are listening today's webinar about this, that so many factors has to be considered before declaring any sample as either as an oligospermic sample or a teratozospermic sample or a normal sample. Sometimes this is very commonly happen that there is written azoospermia, and when we see that there is a few sperms moving here and there, or maybe some non-motels from a seed. So morphology as such for fertilization assessment is very important. You have to focus it, and the fear which I feel in people's mind is that 4% or more than 4% is a normal sample. That is what people are not means you can say they are not able to digest. Is it possible that only 4% is a normal morphology? But yes, it is true, and we have to see morphology very strictly. So for me, yes, for my experience, I can say morphology is a very important factor which determine your success rate in terms of fertilization.
The next question.
Can I ask a question, Yashita?
Okay.
So what is the importance of doing, like, should we do morphology? Again, the question basic arises, should we do morphology for all? And secondly, what is the learning curve for the technique? Because it is not routinely done, sir.
Yeah, so the first thing is that morphology has to be done for all, even if it's a normal sample. Say one patient couple coming to infertility center for doing for their infertility problem. So what basic test we offer them is a semen analysis, right? And right now what is happening is that the semen analysis means they just see the count and motility and just then the male factor is overlooked. They're okay, you are normal, there is no problem. So morphology has to be there. You have to see all parameters of that sample because something has gone wrong with somewhere. So that you have to find out. So I will advise that we should have a complete detailed analysis. Detailed analysis means it will include count, morphology, staining. You do whatever type of tests available. Yes, of course, like there is no need to go for the assessment of fertilization by PIXI or by chromosome reaction and all. But yes, you have a basic idea about that semen sample. And you also know that day to day, these parameters may vary in a semen sample. Like today, if you see a sample, it is a normal sample, but many times it happens that on the day of pickup, we see the sample is subnormal or it's compromised. We don't know, maybe because of stress, maybe because of, so a detailed analysis beforehand is very important and it should be done for all patients coming for infertility treatment.
So the learning curve for morphology?
Yes, yeah, it is simple. It is very simple. More you do, more you learn. And I had done these WHO workshops with Dr. Daniel. That was a fantastic idea initiated and it has given a lot of knowledge to us. And then till last moment, I was asking him, then he was saying that it is matter of practice only. You have to keep on observing, and that's why the kit which they have provided in that, they have a standard morphology slides in it. So anytime in between after 2 months, 3 months, just refresh yourself. Just see that whether whatever we are doing is correct or not, or what is the variation coming in their slide and your result. And that's how you can just keep on improving. You have to believe in yourself that no one is 100%. Like today also, even after 20 years, I cannot say this that I am a perfect embryologist, right? So this is learning curve is always there, and हम कहते हैं कि there is no age for learning. So at any time you should just keep on learning. And now recently I have an advice given by some good friends of mine who have attended the WHO workshop which we organized, that it is long time now. You should focus again, and you should again organize a series of workshop for semen analysis on WHO new criteria. So yes, learning curve is there, but it's not achievable as a nahi hai. One can achieve and one can have accurate results out of it. Only thing is you have to keep patience and keep on learning.
So next
question Dr. Hetal is there. तो वो इतनी ट्रेनिंग करते रहते हैं. Let me ask one question to Dr. Hetal here. Can you tell us about how much one should take time to learn the morphology?
It is. I would say it is. I'm audible?
Yes.
Sure. Yeah. Okay. See, it is not important how much time you are giving to learn the morphology, but I would say it is important to see normal spermatozoa, how many normal spermatozoa you are looking at. Because if you don't know how many, means what is the normal structure of the sperm, you cannot differentiate abnormal spermatozoa. And that is why I would say, I would suggest to look at least 50,000 normal spermatozoa before you start looking for the abnormal spermatozoa who are the beginners in learning of the morphology. my guru, Dr. J.H. Prabhakar, has trained me with this fundamental only, and he was not allowing me to look for the abnormal sperm unless I have mastered the normal structure of the spermatozoa. So
means it is very important to know the morphology.
Yes, very important, very important.
And Dr. Hetal, I would like to ask you one interesting thing which has been asked to me many times and I was not able to answer it. Probably, see, just in continuation to Dr. Ved's question, if we try to apply Kruger's criteria strict morphology, then many people have asked me, sir, if we follow that Kruger's criteria, 100% abnormal sperms are there. What to do now? So what is your say on it that when someone is following that WHO guideline and strict criteria, what compromise, you can say the compromise you can make to just differentiate between a normal? As you rightly said, you have to first see the normal sperm, how it looks, then only you will differentiate. But you also know that 4% is anyway the normal. And if you apply that, and personally, I also felt that if we go by that strict criteria, you will hardly find a normal sperm. So what is your opinion on that?
Sir, my opinion and my experience, means what I have experienced while giving training or while working with many other colleagues and so many things. See, the biggest struggle in assessing sperm morphology, I think it is driven by a mindset many a time. Mindset, and that plays a major role in influencing while assessing normality and abnormality. Mindset, I mean, many people have a mindset that if it is a donor sperm sample, then it will be always more than 4% normal sperm, and if it is a patient sample, then it will never go beyond 4, or it will hardly be 1 or 2%, or many a times, as you are saying, it will be so this kind of mindsets are also there, and that is where I means what I quoted, at least normal structure is, if it is not in the mindset is not towards normal spermatozoa, this kind of problem, that's what I was going to ask you, sir, that have you ever faced this kind of problem of mindset? When, because you have a very vast experience, and also
see, I think our mindset sets at the time when the sample comes to you from an infertile couple.
Yes.
From that point of time only we start thinking that what is problem with this sample? Probably exactly. There is no problem. But we just start thinking in that way that yes, we have to find out the abnormality, we have to find out something, that why the sample is, why the pregnancy is not achieving and all. So you rightly said, it may be the mindset we are looking for.
And many a time, sir, it is a defense mechanism also. You were pointing that once you put them for fertilization, sperm, if you are doing IVF or anything, and next day embryologist has a fear tomorrow, if it fails, then what is my defense? And the softest target is morphology. Sperm and the morphology.
So then immediately next question will be asked to you, sir, that what if you find that the morphology was normal, not normal, then why you did IVF? Why don't you do ICSI?
I have a question. I see many times embryologists perform ICSI with abnormal sperm.
Correct.
And that abnormal sperm is giving a very healthy live birth also.
Right.
Sir, that is another area which you are touching. The problem is that whether to find, if you declare some sperm as abnormal, then whether to take that sperm and inject it, that is itself is a question. Exactly. We all have come across a situation. Paresh Bhai will also agree on it, that there are so many fragmented grade 3, grade 4 embryos. We have no choice. We transferred and we got the pregnancy.
Correct.
Right.
Yes, sir,
So that is a gray area actually. You cannot comment on that. But
No,
yes,
sir,
this semen analysis is very important. I feel it should be given its importance. That is not given right now.
No, very much important.
Hetal sir have lots of experience on andrology, sir. But I want to ask one question. Do you really found the 4% morphology when you are studying the slide? Because I don't know why when we are doing the morphology check, most of the samples are 0% morphology. Actually, clinician is not ready to hear that. Every time we are giving 0% motility, 0% morphology.
Actually,
literally we are having 0%, 1%.
Actually, here I want to add one thing. Actually, as rightly said by Dr. Hetal, first you have to check normal sperms. Okay, first you should be expert in see the normal sperms, because what happened, we sitting on the microscope to see only abnormal sperm. We are not checking normal sperms. We are only checking abnormal. We are trying to find out what is where is the abnormal sperm. We are not finding out the normal sperms. That's why I'm telling mindset is like that. We are sitting on the microscope like आप एक हिंदी में कहते हैं ना, आप तो गलती ढूंढने के लिए बैठे हैं, तो जो गलती ढूंढने के लिए बैठे ना उसको गलती गलत नजर आता सारा. आप गलती ढूंढने के लिए मत बैठो, आप उसमें रियल उसको ना नॉर्मल और उसको एबनॉर्मल में डिफरेंशिएट करना है.
I would like to add one more, Paresh bhai. There may be one reason for that. See, I have listened one webinar or one conference lecture on this, particularly this topic, that the semen analysis part. Whatever is WHO has taken, that data is from Indian subcontinent. The data is not much shared, right? You see, we may have a different kind of setup. So probably हो सकता है कि 4% हमारे लिए ना हो, हमारा जो है वो कुछ ज़्यादा भी हो सकता है, कम भी हो सकता है. I remember a very good incident when we were conducting this WHO workshop with Dr. Daniel. One participant wrote 65% normal sperm, and he was just like, oh, what is this? He's a superhuman. And he just sat on the chair. मैंने कभी सोच भी नहीं सकता कि 60% normal हो सकता है. So anyway, what I can conclude here is that the semen analysis morphology is an important and integral part, and it should be given its due importance. And one should focus, and learning curve is always there. I feel you just keep on learning, and ultimately you will come to a conclusion. ऐसा नहीं होगा कि आप अंदर में भटकते रहेंगे और आपको कभी भी नॉर्मल नहीं मिलेगा. डेफिनेटली नॉर्मल स्पर्म मिलेगा.
सर Q&A में एक रिपीटेडली बहुत ही कॉमन क्वेश्चन आ रहा है. योशिता, कैन यू आस्क दैट क्वेश्चन टू सर? योशिता, आर यू देयर? ओके सर, आई विल आस्क द क्वेश्चन. हां, या जस्ट आस्क द क्वेश्चन जो रिपीटेडली आ रहा है सर से.
One second, let me see.
नहीं, कौन से सर से, मतलब मुझसे पूछ रहे हैं?
कौन से सर आपसे? I'll just ask it.
Can one tell the gender of sex during ICSI using morphology of the semen?
Yes, sir.
And one more question from same person. How can morphology?
पहली बात तो मैं यहाँ ये बताना चाहूँगा. Please don't ask this kind of questions. It is banned in India, and it is definitely it is not possible.
Yes, डॉक्टर साहब, let me answer this question. जो भी है भाई साहब है, बहन जी है जिन्होंने पूछा है, तो बेसिकली अभी जो नया ART बिल है ना, यू शुड रीड दैट. उसके अंदर उन्होंने इसको भी इंक्लूड किया है कि अभी तक जो बोलता था करने के लिए उसको कुछ प्रॉब्लम नहीं थी, जो करता था उसकी प्रॉब्लम थी. अब ऐसा उन्होंने उसको भी जोड़ दिया उसमें कि जो बोलेगा और वो पकड़ा गया तो उसको भी वही सजा और पेनल्टी है ना. तो पहली चीज तो ये कि नो एंटरटेनमेंट टू सच क्वेश्चंस. कभी आपके क्रॉस भी होता है कोई और कुछ पूछता है तो स्ट्रेट वे यू से नो, वी कैन नॉट टॉक ऑन दिस, डोंट इवन टॉक अबाउट दिस, that this is possible. Now it's coming to your second question, that whether it is possible. Absolutely it is not possible. This is a misconcept, and particularly in our place it has happened. Like the PCPNDT people, somehow they came to know that by ICSI they are doing the gender selection, and they have literally asked to all IVF centers to submit the report, how many ICSI is done, how many pregnancies achieved, how many male babies, how many female babies, and all. And it is an hell of work now, because we are supposed to give them the complete report. So yes, it is absolutely no possibility is there that you can select a sperm and inject particular, yes, PGD, PGS, that is other options which is not available to everyone. That also needs to be specific conditions are there for which you can avail that service. But as far as semen is concerned, I don't feel that there is any method which can give us a practical differentiation between a male and female sperm. So my advice will be never ever ask this question, or never ever give any suggestion on this question, because this is a modern era. You don't know who is recording and what is recording. So as our presidents are directly said, Ved sir, you should not involve in this. No, not at all.
Okay. So one last question is there.
Mm-hmm.
Is there correlation between morphology and DNA fragmentation?
Very honestly, I don't have much experience of this. Probably Ved sir can answer this. Or Paresh, you have any experience of this?
Sir, I actually, what I experience is there is no relation between the morphology and DNA fragmentation. Because, actually, how I am selecting the spermatozoa, I am doing first, they are doing a DG. After DG, we are doing the microfluidic. After microfluidic, I am using sperm slow. The sperm slow is contain the hyaluron and it select only the mature spermatozoa. And again, I am doing the MC. But I am always surprised when I am doing MC after all this filtration, I am finding abnormal spermatozoa which are sticking to hyaluron and that are mature spermatozoa and that are passed with a different filter. So personally, I feel that there is no relation between the morphology and DNA fragmentation.
Only selection, doing selection on the basis of morphology, you can achieve good fertilization. After that, nothing else. I don't think any special thing where any miracle can happen.
Sir,
yes, please.
Morphology is not directly related to the DNA fragmentation, but motility definitely has some positive correlation to the higher DNA fragmentation. Means if a teratozoospermia may be acceptable DNA fragmentation will be there, but with asthenozoospermic sample, definitely higher DFI will be possible. Yeah, it is very likely.
Okay, I think we should move on.
Thank you, Rohit.
Now we have to move.
Let's start with our last lecture of this evening. I welcome Ms. Alicia John. She has done his MSc in clinical embryology and pre-implantation genetic from Asia Pacific Institute of Andrology, University of Mysore. She is working in as an embryologist at Southern Fertility and IVF, New Delhi. Welcome, Alicia.
Good evening to everyone. In the next few minutes, I'll be talking about the agglutination of sperms and the presence of WBCs in the semen. While assessing the semen microscopically, we can see that sometimes the sperms are stick to each other in a way that it makes the assessment difficult. So this is known as agglutination. The attachment of the sperms to each other could either be head to head, tail to tail, or in a mixed way. And after the attachment, you can see that the motility of those sperms will be vigorous with a shaking motion, and if it's too much agglutinated, then the motion will be limited. Agglutination is a part of the routine semen examination. A point to be noted here is that the agglutination should not be confused with aggregation. In agglutination, only the motile sperms are seen sticking to each other, whereas in aggregation, motile sperms may be seen sticking to non-sperm cells, mucus strands, debris, or other immotile spermatozoa. What is the significance of agglutination in semen analysis? If the sperm show agglutination, then there is a possibility that the semen sample can have anti-sperm antibodies. So these have a cytotoxic effect on the spermatozoa and can cause cell death and cell immobilization. The ASAs create agglutinated clumps of moving sperms in the semen sample, hampering the passage through the cervical mucus and zonal binding. So this can affect the assessment of sperm motility and concentration while semen analysis. Its consequential inhibition on sperm motility may play a significant role in the pathogenesis of male infertility. But agglutination is not sufficient evidence to deduce an immunological cause of infertility because sperm antibodies can be present without sperm agglutination. Equally, agglutination can be caused by factors other than the sperm antibodies. So regardless of the presence or absence of the ASAs, other risk factors of agglutination could be scrotal trauma, scrotal surgery, ascorbic acid deficiency, and male accessory gland infections where the E. coli rapidly adheres to the human sperm, resulting in the agglutination of sperms. The grading of agglutination should reflect the degree of agglutination and the site of attachment. So the types of agglutination reflecting the site of attachment would be graded from A to E. A for head to head, that means the sperm heads will be seen sticking to each other. B is tail to tail, that means the sperm tail will be seen sticking to each other and the heads will be seen clear. And the C will be for tail tip to tail tip, only the tip of the tail stick to each other. D, as you can see, is mixed. Mixed means both the head and the tails may be sticking to each other. Tangle could be that the heads and tails are so much enmeshed that the heads are not clear of the agglutinates as they are in the tail-to-tail agglutination. Types of agglutination reflecting the degree of attachment will be graded from 1 to 4. So the first one will be isolated, that is less than 10 sperms are seen sticking to each other and there will be many of the free sperms. Then there is second grade, which is moderate, where 10 to 50 sperms are seen agglutinated and there will be still many more free sperm. Then there is large, that is third grade, where agglutinates will be more than 50 sperms seen attaching to each other and some of the sperm will be seen free. Then there is gross, in which all the sperms are agglutinated, so you can see many network of agglutinates. For observing agglutination, we need to prepare a wet preparation slide. For that, first take a plain glass slide and label it. Then take the semen which is liquefied and pre-warmed at 37 degrees Celsius or room temperature. Take around 10 microliter of semen. Place a drop on the glass slide. Place the cover slip without trapping air bubbles. Wait for the sample to not drift from the cover slip. Then observe. Do an initial scanning at 10x where you can see if the sperms are sticking to each other. So you can see that then you have to observe it at 40x. Once you have seen that there is agglutination, then you have to grade it as grade 1, grade 2, grade 3 and grade 4 and with the types of attachment. Other than the mature sperm cells, there are cellular elements in the ejaculate which may be clinically relevant. These are the cells of non-spermatogenic origin like the epithelial cells from the genitourinary tract and the inflammatory cells or the immature sperm cells. These are collectively referred as round cells. This brings us to the second topic, which is the detection of leukocytes in semen. So why do we need to differentiate the WBCs from other round cells? The elevated concentration of WBC is an indicator of acute infection or inflammation of the genital tract and poor sperm quality. The leukocytes in semen may produce oxidative stress and cytotoxic cytokine secretions, which affect the sperm progression by affecting motility, morphology, and DNA integrity. These are the two methods recommended by the WHO for testing of leukocytes. First method is to stain the cellular peroxidase using orthotoluidine, and second is the CD45 immunocytochemical staining. Cellular peroxidase is the most common method that is chosen because it's quick and cheap. The principle of peroxidase staining is that the peroxidase enzyme is a characteristic of the granulocytic leukocytes. Therefore, it will stain all the leukocytes which contain the peroxidase enzyme, which is the neutrophils, the basophils, the eosinophils. And therefore, it could be used to distinguish them from the spermatozoa, which does not contain the peroxidase. But the only disadvantage that this test has is that it will also not stain the other leukocytes which are peroxidase negative, that is the lymphocytes, the macrophages and the monocytes. So since not all leukocytes are peroxidase positive granulocytes, therefore a threshold value of 1 million cells per ml for peroxidase cells implies a higher concentration of the total leukocytes. For the staining procedure, there are many ready-to-use reagent kits available in the market. This is one of them. The reagents contain phosphate buffer, saturated ammonium chloride solution, EDTA and orthotoluidine. And this test is recommended only if there was a significant amount of round cells present in the routine semen examination. This is the staining procedure. Take a microtube or a cryo vial and label it. Also measure the complete volume of semen before you start. Take around 900 microliter of reagent 1 in the microtube. Add 100 microliter of liquefied semen and mix well. Add a drop of reagent 2 into the cryo vial and mix well. Cap the microtube and shake it well for 1 to 2 minutes. Alternatively, you can use a vortex mixture for 10 seconds. Then keep the microtube at room temperature for around 30 minutes. And after that, take around 10 microliter semen on the counting chamber and assess it under 20x. Alternatively, you can use a glass slide take a drop of semen and put a cover slip and observe it under 40x. What you will see is, after you count, the unstained or the pink colored ones are the peroxidase negative cells. The dark colored, the brown or black, are the peroxidase positive cells. You can count the cells in around 10 squares of the counting chamber. For the calculation of the peroxidase positive cells, if you are using a counting chamber, then you have to count the number of brown colored WBCs that you saw in any of the 10 squares of a row. The second test is CD45 immunocytochemical staining. The principle of this test is that all class of human leukocytes express specific CD45 antigen that can be detected with an appropriate monoclonal antibody through immunocytochemical staining. So this procedure allows the detection of different types of leukocytes. Even though this test is more expensive and time consuming, but it is more advantageous because it's more sensitive and it includes the whole class of leukocytes. So winding up my presentation, my take-home message is that the attention should be paid to the agglutination of spermatozoa, and testing for anti-sperm antibodies must be done in such situations, and men with pyospermia must be evaluated for peroxidase activity to rule out any history or present genital tract infection, and semen analysis, when performed along with a detailed medical history and thorough physical examination, can provide an accurate picture of the male's fertility potential and guide the right treatment. Thank you.
So can I ask a question? Ishita, are there any questions in the chat box?
No, there's no question. You can ask.
Charu sir, are you there?
Yeah.
Yeah, so what's the cost the cost of this test for a patient or routine for a lab also? Or is it cost effective or is it not, the peroxidase testing?
No, it is not that cost effective right now because, what I came across now is there are various Indian companies have come up with the kits and all, and they are making reagents here. So probably that may reduce the cost involved. But in routine, how many people are preferring doing this peroxidase staining? I don't know. It is for the infertility centers only. Mostly they can only perform this in routines, although it should be part of routine analysis. But I don't think it is commonly done. So
the question again is, sir, should it be a part as a routine? Again, the question, so as per you, according to you.
See, again, the answer is same, that as many as possibilities are there, you should do as a routine analysis. The question comes at the end is that even if peroxidase testing is done and the report is negative and all, what is alternative you have? The question asked is this: so why to spend that much of money when we have other things also available to proceed with? So yes, it should be, ideally it should be part of a standard semen analysis, that if you see, or at least where if you see more number of WBCs or more number of debris or kind of dirty kind of sample, then you can just keep an addition of this peroxidase staining in the such kind of sample.
So we have one question in our question answer box. What is the cause of leukocytospermia?
Dr. Saab can answer this. Cause, I don't know.
So leukocytospermia, basically you just try to understand, leukocytes are like pus cells in the sperm, semen. So it is maybe because of some infection.
Yeah,
for a
layman purpose, if we say it is a kind of, it is just presence of infection in the semen, that you can just consider.
And definitely it has role. If you see so many round cells, because you confused at the time of doing that, morphology. So sometimes most of the people writing pus cells. It is not like pus cells. Sometimes it is round body, mature cells are coming from testes. So we have to differentiate about in between them. Is it round cells or is it the pus cells, actually leukocytes? So for that reason, you need to do that special peroxide staining. What we are talking about that. And nowadays, Indian companies are also making that, and it is very cheap. You can easily perform in the lab, and you can get the result. And of course, if leukocytes are there, then definitely you have to go for culture and rule out the infection. Okay.
And I think it's a standard procedure now in our country, that we give antibiotic, broad spectrum antibiotic coverage before enrolling patient for IVF and ICSI. It is, as a routine, it is given either infection is there or not. But yes, if infection is there, definitely. Dr. Saab, one question I have: if you are seeing on slide 2 round things, saying one is pus cell and one is immature sperm cell or round spermatid cell, or how one can just say that this is
that's why I'm telling it is necessary to do that peroxide staining.
No, if peroxide stain is not available, then
you have to see that nucleus. Actually, you know that if you have seen the leukocytes, but definitely you can make out.
Yes.
Yeah.
For me, the differentiation is that in the spermatid cell or a round sperm cell, we see the black bodies inside. And as far as WBC or leukocyte is concerned, they are more translucent kind of, transparent kind of structures. Both of them are round.
Multiple nucleus, maybe you can see in that.
Yes, both of them are round. एक गोरा होता है, एक थोड़ा सावला होता है.
So one more question is there.
Yes.
What will the best method sample preparation with leukocytospermia?
See, I have already answered in the chat box to some question that the double density gradient is a gold standard method in today's scenario for all kind of analysis or all kind of semen sample preparations. Right?
Dr. Hetal is there?
Now, I'm surprised no one has asked that if agglutination is there in the semen sample, what to
No,
do with
nobody
that.
bothered about
Nobody
that.
bothered about. See how you can process a semen sample having agglutination in it.
Exactly.
Yeah.
So, Dr. Hetal, I think you only throw some light on this.
The semen sample with agglutination, very high degree of agglutination and semen preparation, maybe dilution of the sample with the culture media may help, and double density gradient or semen swim up with a very, very low volume of the media may help to let the sperm come up, and you can choose the
probably we can go for double washing. Once you wash it, spin it,
yeah,
then again you wash it. So probably it will reduce the load of this, and you can have better quality of sperm. Although the count will be less, but you will have good sperms.
Very, very true.
Actually, sperm preparation always help in that kind of samples. Maybe double density is better choice for that. Always use double density method.
For our audience here, important thing which is mentioned here in agglutination topic is to differentiate between really whether it is an agglutination or it is just an aggregation kind of thing, which is very, means normally we just see that, okay, there is a clump of sperm and we report agglutination. The whole line of treatment gets changed. Just you write it is agglutination. Okay, and there are reports I have seen agglutination present 3+. What is 3+? I don't know. 3+ agglutination. 3+ agglutination means a very high degree, as per my understanding, very high degree of agglutination.
Sometimes what happen without liquefaction, people start doing the procedure.
So that is very commonly seen.
Always wait at least 20 minutes, minimum 20 minutes. And check
even if in 20 minutes it is not liquefied, give some more time, add some media, wait, and then see. Then only you reach to a conclusion whether agglutination is there or not.
Maybe Dr. Jayalakshmi is there. Jayalakshmi, can you?
Yes, sir. Yes, sir.
Yeah. Can you answer this question?
One second, sir.
Agglutination. We are talking about agglutination.
Just a minute, sir. Can you please repeat the question, sir?
Jayalakshmi, it is very simple. It is very simple question that if you get agglutination, how to get rid of agglutination in the semen sample, and what strategies you?
Connection problem.
Okay.
Yes, sir.
The question is how you will differentiate. What strategies you apply in your routine practice to differentiate between agglutination and aggregation? And second thing is what procedure you will apply for getting rid of these agglutinated sperms, or simply separating them from each other?
Sir, actually, honestly speaking, we hardly have come across such things because basically I don't do the semen analysis. Even when we have done it, I have very less experience in this. But then, we do see when we do ICSI in procedure. But then I think we do double density gradient and swim up, sir. Probably the recovery is less, but then you do get sperm in the swim up.
Yeah.
Okay, so I think the take-home message here is that you should always go for a density gradient. That is a gold standard technique today for preparing any kind of semen sample. And the second thing, particularly if you see high grade of agglutination, probably double washing is an answer to it to get rid of it.
One more thing, you know that all the parameters are normal except agglutination. Female is also normal. Okay, so would you advise her for IUI or maybe IVF, or you want to treat it? Medicinal treatment. What you will advise? All things are normal
Sir, can I answer this? I think
please.
Pre-analysis is definitely required before you take up such cases for any further treatment. And then if it can be clinically treated, I think the patient should undergo the treatment first and then again do the semen analysis. And probably that will work much better rather than just taking them for any procedure. Or even if you know that they have certain problem like agglutination and then you take them for any procedure, I think the pre-treatment is very much necessary here before they subject the couple for any kind of treatment.
You are right. Definitely. That's why I asked this question. Actually, sometimes what happens, patients are young. You cannot advise directly for the procedure.
Yes, sir.
And everything is normal.
True.
So for giving a treatment, maybe because of infection, agglutination is there. Maybe antibodies are creating problem. So why not to treat these patients? Because easily you can treat these patients. So it is better to treat first and after go for any procedure to get the best result.
Sir, can I ask a question? I have like this agglutination or aggregation when we see. Have you ever seen that the whole, whatever sperm you see is aggregated or agglutinated? Sometimes what happens is we see certain portion of the sperm, they agglutinate to each other, and certain portions, certain sperm are like, freely motile. So have you ever seen that you don't get anything for the procedure, no sperm you are getting for the procedure?
Sorry, actually we are not able to hear your voice properly. Sometimes it is low, sometimes it is high.
Oh, 1 second. Can you hear me, sir, now?
Yeah, please.
Yeah, have you ever seen any sample where all the sperm are agglutinated?
Right.
You don't get any free sperm for it. Like, say you are sitting, you are doing ICSI, and then you suddenly see this agglutination, and then you don't get anything for ICSI. Like, all are agglutinated. Have you ever come across such a situation?
No, I haven't seen. No. Vital sir, can you please tell us, because you are the main person who can tell us about this. You are dealing only sperm. Please unmute yourself.
Yeah. Till the date, I haven't seen 100% agglutination. No.
Probably it is highly viscous sample. You can see there is no free sperm moving, but I don't think there is 100% agglutination. I have not seen it.
So sometimes people are in so hurry that they start doing analysis without waiting of liquefaction.
True, sir. Okay. Thank you.
But anybody has, I have no idea about it, but has anybody ever tried this commercial available enzymes which is used for liquefaction? I mean bromelain or plasmine or chymotrypsin or something like that.
I haven't used that. No.
Are these enzymes safe when we use the sample for any procedure, sir? Are these enzymes okay? Use them to break the viscosity or agglutination? Are these okay? Or we are not supposed to use? Because I think for the analysis purpose, we need not have to use anything like this. To use the sample for certain, for the procedure, we might have to do this. Are they safe, sir?
Actually, there is one enzyme is available which we can easily use in that semen preparation sample also. It is, I think it is chymotrypsin. Trypsin. So there is one company who is promoting. I think it is from South only. That क्या नाम है यार उसका जो वो है South Indian लोग कैसे ना
Krishko, sir.
They are promoting that kit.
Okay.
So you can use that thing easily according to them. But I haven't used.
Even I haven't even tried anything like that, sir.
Can I ask a question to all of the people, senior people? What are the causes of sticky sperms during ICSI? It's a little bit out, but it's not a part of semen analysis. But do these factors affect to a sticky sperm? What can be a cause of sticky sperm during ICSI?
चारों सर, आप बहुत करते हो प्रेस सर. Paresh and Charu can tell us. Paresh,
No,
are you there?
Ideally, there should not be this problem coming during ICSI that sperm is sticking inside. Previously, with few companies injecting needle, it was there and they have rectified it. It may be because of the coating inside is not proper, or maybe the priming of the needle is not done in proper way. Then also there is a possibility that sperm gets stick inside. The most important part is that sometimes, particularly in abnormal morphology sperms, right? If you see particularly see like testicular sperms, if you see and you want to do ICSI, then it is always advised that you use a slightly wider bore. Like normally we use 5 micron inner diameter. So for that, we advise to use 5.5 micron inner diameter. So there is slightly more space for the sperm to enter, because you see the head is abnormal. In the PISA sperm, particularly, you see this thing that there is either something is attached, some cytoplasmic droplet is attached or something, so it doesn't go easily inside your pipette. So there, maybe it will stuck inside and then it can cause problems. So primarily, what I feel is that if you don't do priming of your needle rightly, then there is always a possibility of sperm getting stuck inside due to surface tension, but you always wash it and you can take it out. That's not the issue, but it rarely happens that the sperm gets stuck inside if you do priming properly. That is what I feel.
And mostly in PISA sample this happen actually. PISA sample or
That is what I'm
sometimes
saying.
viscous sample.
PISA sample you cannot
also.
consider the normal head size and normal this thing. So sometimes the high concentration of sperm, if you have taken, that is also one of the reasons. You have to have very diluted semen sample for ICSI. So if you add a more number of sperm, then also this is possible.
Yes.
So coming back to, I think so I'm the one asking more question. Coming back to semen analysis, if a couple is undergoing treatment and the semen analysis is done, again the couple comes back and all the procedures are done, 6 months have passed. So what is again, should the husband undergo repeated semen analysis, or the first semen analysis should be considered then 6 months back? What do you think?
It is better to go one more semen analysis before starting any procedure. In between, there may be history of fever and any other infection, so it should be ruled out, because sometimes that variation is very frequent in this kind of patients. Every patient, most of the male patient nowadays, you can see today's sample is normal. Again, after 2 days, you will find there is no sperm, cryptogenic sometime. So it is better to do semen analysis. I think at least in 6 months, at least once, so you have to go for that semen analysis.
I have a better option, Nidhi. You can just off the record, you can advise this patient. You should have the data when they come to you, what was their mental status or mental stress level. And then after 6 months, when they come back, you again ask them, are you free from mental stress now? if they are still in that, then there is no point in doing it. And if they are free out of that mental stress, you can definitely go ahead with a normal.
तुम एम्ब्रोलॉजिस्ट का मेंटल प्रेशर बढ़ा दोगे तब तक.
No, but believe me, this happens. What Ved is saying is rightly. You see, every sample in itself is a different kind of sample, and you cannot make a common strategy for. Today, yes, definitely, as I said, when it normal analysis के लिए patient आया, at that time everything was good, and on the day of pickup, when you give the sample, you hardly find any sperm.
Yes, sir.
Maybe the sample collection is not properly done, or maybe any reason is there, but then you end up in an unexpected situation.
You know, there is one incident happened in our lab. The patient, whenever he came to for semen analysis, there was no sperm. 2 or 3 times he has done. So that patient sent to me in other center. He came to me and he was actually telling me that my sample is all the parameters are normal. Why not your technician is not able to find a sperm? Because whenever he do semen analysis at their center, semen sample is all normal. He showed me reports. Then I advised him, please come in the morning at our center. There will be nobody here. You just go, I will provide you a separate room. You just provide a sample. He came in the morning, and that day I saw that semen was absolutely normal. There was so many sperms count and everything was normal. So maybe sometime what happened, because I have done some, that sexual medicines also. If orgasm is not happened, proper orgasm, then definitely it impact that only fluid is coming out, sperm is not there. So that is definitely you need a separate room where no disturbance is there, so patient easily can give the sample. It is always provide them separate room without disturbance.
This is very important. This is what is mentioned in the guidelines also, that you should have a well-equipped room for collection, because that's a very important procedure for the patient.
So I think we have come at end. ये तो नहीं तो चलता रहेगा. So चारू जी, please थैंक यू कर दें कूपर सर्जिकल को.
बिल्कुल कर दिए सर, बिल्कुल कर दीजिए.
करो आप.
वैसे I would like to thank all senior, all my dear moderators, my dear conveners, and our loveliest Dr. Ved Prakash for organizing and giving such opportunities to young people. Today's scene was what I felt good about this is that today the young people, which they are behind the scene, they are working day and night on semen and all, and they got a chance to speak. And so this is a good exercise we have started. And this is right time now, as someone advised me, I told already earlier also that we should think of another series of WHO workshops for semen analysis. Maybe in coming time, we should plan it in different places as we did earlier, and probably that will give you better insight. So with this, I would like to thank once again to all our people who participated in today's wonderful webinar and enlightened us with their experiences. And also thank you once again from IHERA.
So from my side, I want to thank all of you, all the coordinators, all the faculty, senior faculty, and all the junior faculty. I must say that they have done wonderful job. And I myself learned so many things from your slides. I have seen yesterday night, they share with me all the slides. Really, it was very wonderful, and I learned so many things out of that slides. So thanks to everyone, and thanks to Cooper Surgical. Special thanks to them, because they have the people who provide us the platform to run this kind of program for all the junior. This is basic embryology. We have started to teach all the people, not to teach, to share the knowledge. Okay, so definitely next month we are doing some another webinar on culture medium. So do join and learn so many other things also from the juniors or maybe from our seniors people also. Thank you so much.
Yes,
thank you, everyone.
Thank you.
Thank you, sir. Thank you all of you.
Thank you so much.
Thank you, Vakil. Thank you, Vakil. Vakil is there?
No, Vakil is not there, sir.
So
he's still in the train.
So please tell him thanks.
Sure.
Thank you so much. Thank you, everyone. Thank you so much.